welcome to Migraine New Zealand, Migraine Awareness Month in New Zealand. This is our first ever Migraine Awareness Month. And today I am joined by Debbie Hay, Professor at Department of Pharmacology and Toxicology in Otago. Welcome, Debbie.
Kia ora, Briar. Thanks a lot for having me here today.
That's right. I'll let you take over and introduce.
Yeah, sure.
I'll
introduce myself briefly to all of you out there. So, kia ora koutou. My name's Debbie, and I've recently joined the University of Otago from the University of Auckland, where I've been for about 20 years. So I'm enjoying being now down in Dunedin. I personally don't get migraine, but my research area has taken me on a journey to understanding migraine, at least attempting to understand migraine. So I've started in research relevant to migraine probably about 20 years ago when I was over in the UK. And since that time, I've learned more and more as I've gone on that journey. So my area of research is broadly pharmacology, which for those of you who don't know is about understanding how medicines work and developing new medicines. And a lot of that means that we have to try and understand some of the molecular aspects of how different drug targets work. So one of the areas that I work in relates to a natural hormone that we all have called CGRP, and you may or may not have heard of that depending on what you've been looking at in terms of some of the new treatments that are out there. But I first heard about CGRP a long time ago. For my PhD, I studied it. This is a natural hormone that we all have. It's found in our nerves that control pain. And over the course of time, researchers found that people living with migraine seem to have more CGRP. And so that led to a lot of research that I've been part of to help understand how CGRP causes that pain, whether it contributes to other aspects of migraine beyond pain, because we all know that there's an awful lot more to the migraine experience than just pain.
Absolutely.
And then finding ways to see how we can stop it in its tracks, block it with different medicines, and therefore finally provide some relief to those who don't find anything that can help treat them at the present time. Mm-hmm. So yeah, I have an active research lab down here in Otago, and we are trying to make more headway into understanding how this molecule CGRP works, what its exact cellular targets are, where in the brain and in the nervous system these are found, to help develop new and more effective treatments for migraine. So I guess that's a little bit of a summary of who I am and what we do here.
Yeah, wow, awesome. 20 years in Auckland is a long time to then move down to Otago, and then obviously you were in the UK prior to being to Auckland. What led
I was born in the UK.
Right. What led you to New Zealand?
Well, I met a Kiwi in London. You know, these things happen. So.
Right, so it wasn't the job that came first.
One of those life things that made me think about it, but no, I came into New Zealand with a job at the University of Auckland, and it's been fantastic for my career. Yeah. And I think that something that's important for those here in New Zealand to really know is that we're making a global impact in this area. Mm-hmm. You know, what can we do here in New Zealand? Actually, by doing research in this space, this is making a real contribution to what's happening internationally.
Absolutely.
So I've never felt that moving from the UK to here was a bad move at all. In fact, that has positively made my career.
Which is amazing. Little New Zealand. So CGRPs, there is 3 known types of them. So the Ajovy, Imagility, and the last one escapes me.
So I can briefly talk through those if you like, what those drugs are. Yep.
I know we have
as I say,
Imagility in New Zealand, which has been MedSafe approved, however, is not funded in New Zealand.
Yeah, that's right. So just to fill everyone in on what the landscape is looking like here with these medicines at the moment. So I'll start from like the international perspective of which drugs have finished all their clinical trials and which ones are approved for clinical use in different places. There are 3 different types, as Briar's just said. We've got 2 different types of antibodies. We've got antibodies that target the CGRP peptide itself, which is that we've got more of if we have migraine. That's what the data shows. So that sort of mops up that excess CGRP so it can't produce its painful and other effects. And there are 3 different drugs that have that mechanism. So they're all antibodies against that CGRP molecule. And there are 3 of them. There is galcanezumab, known as Emgality, fremanezumab, and ectinezumab. And each of these have a really similar mechanism of action. 3 different companies developed them. They were all kind of racing for the finish line in terms of who made it there. But there are subtleties in exactly how they're administered. For example, ectinezumab, that's given intravenously, which means you can't do it at home yourself. You have to go into a clinic and do it, but it acts really fast and you don't have to take it very often. The other 2 are given by a subcutaneous injection, which is really like an insulin injection if you're diabetic, and that can be once monthly. So all of those 3 have got really interesting positive benefit for many migraine patients, not all, but for many, and they target the CGRP peptide itself. There's one other antibody, which is called Imivig or Ireneumab. That was actually the first one to be approved. That's the one that won the race. Doesn't make it better than the rest. It just happened to win the race. And that targets not the peptide, the hormone itself, but the cellular target for that hormone. So its molecular mechanism of action is slightly different, but it's essentially doing the same thing, which is reducing that effect that CGRP has on producing those painful effects. Since all of those have been approved for clinical use in different places, there are 2 other ones which have also been approved, and they are tablets or oral medications rather than injections. And so they are not antibodies, but they're more like a classic medication that you might take, say, for blood pressure. They're called small molecules, which is just their chemical structure. So they're absorbed into the bloodstream when you take them in the mouth, and they are not for migraine prevention at the moment. They're an alternative to triptans for acute migraine treatment. So for people who find the effects of triptans intolerable or they aren't effective, this provides another acute treatment for them. They are called Ubrelvy, Ubrogepant, and Rimegepant. So big complex names, but they're also targeting that cellular target of CGRP. So that's 6 now. And the important thing about all of those 6 is that broadly they're all targeting CGRP, but they have subtle differences in whether you take them as a preventative or as an acute treatment, how long they last. And that's good because it can, in theory, then provide some flexibility. So for so long, people living with migraine have had so little choice in what they can take. And now we have these 6 here, we're targeting this new mechanism of action, which could be a bit overwhelming. But actually, it's a really positive thing. And there are more coming in the pipeline that target this. Now, in terms of New Zealand, what we can access here. MedSafe approval has been given to 2 of those antibodies, Imivig and Emgality, but of course this comes at a price. And what we've all got to do is get together and campaign for Pharmac to fund these, because the benefits to this are absolutely substantial where these drugs are right for you. There's clearly so much benefit to them that it's really important that Pharmac does consider an application on this. Now, those small molecule drugs that I talked about, they are going to be cheaper, which may be really advantageous, but if you really need prevention, they're not going to be good for that yet. But there are some others coming in the pipeline that hopefully will be approved and will be able to be used for prevention and will be cheaper. And so again, the point of this is that the future is looking bright. We may not be there yet. We may not have the Pharmac funding yet. We may not have all of these drugs approved yet. They may still be expensive, but the options that are coming through are just so much greater than there has been, frankly, for decades.
Absolutely.
So where you've been living with migraine for a long time, you've been seeing your doctor, your neurologist, you're getting nowhere, you're trying all sorts of different things and nothing's working. These now do offer a fresh perspective and some fresh hope, because these drugs have actually been designed to target an underlying mechanism of migraine. Most of the other preventatives, in fact, all of the other preventatives have come from other therapeutic areas. So it might be that one of the drugs was originally designed for blood pressure, or it was originally designed to treat epilepsy, and people happened to notice that there was some benefit to migraine patients. But that was never designed to treat migraine.
Yeah.
So what's really crucial is there's more research, more evidence helping show us a path towards actually targeting what is causing migraine in the first place. And so, yeah, my main point would be that the future is much, much brighter than it has been.
Yeah, absolutely. And there has been, I have spoken with a few people in the community that have had Imagility through, they have purchased it themselves from a place in Auckland, and it has cost them, for I believe it was the smaller dose, about $600 and something, which, you know, if with migraine being a burden on people, not being able to work and things like that, you know, the price for everyone of that isn't doable. And so absolutely our plan for Migraine New Zealand is to make plans to lobby for better medication here in New Zealand, but we do know that there is hope for us, and we will get it at some stage. Absolutely. And in regards to those, I know you said the pain, CGRP is pain. What on vestibular, for people that don't have pain, do you have any knowledge, research on that? Do they still work the same?
That's absolutely crucial. I mean, we talk here migraine broadly, but migraine is an example of a primary headache disorder of which there are many different subtypes. And actually acknowledging and appreciating the breadth there, that whilst characteristically this is, you know, severe one-sided head pain, which may or may not have aura, that absolutely does not do justice to the breadth of migraine. And actually where getting a diagnosis is critical, because it's very diverse in how it presents itself. So vestibular migraine, as you've indicated, is another example. And through the Facebook page and other things, you know, just seeing what people are saying about their different types of migraine and how it's affecting them, you know, it's really important to help us all understand the breadth of that condition. At the moment, the CGRP targeted drugs haven't been specifically tested in vestibular migraine, but they're is work going on to understand that. And I guess because these are the first ones targeting this mechanism, they've gone for the largest cohorts of patients, the hardest to treat, the chronic migraine. But we will see over time more trials. But regardless of the CGRP therapies, what it shows us is that we don't understand what causes all the different flavors of migraine, I'll call it. So why do some people have vestibular migraine? What does that actually mean? Why do some people have chronic migraine? What does migraine really look like in a child? How does that change over the course of someone's life? We just don't have enough research into understanding that at all. And from my experience of attending some of the big international headache meetings, it's really, really obvious that overall, considering the prevalence of migraine, it's massively under-researched, be it in terms of training headache specialists in medicine, diagnosis, other forms of health practitioners, research. You know, the kind of attendees that you would see at the main International Headache Congress might be, say, 1,000 attendees. If you went to a diabetes meeting, it would be 20 to 40,000. Why? What we need to do is inspire neurologists, inspire our future doctors, inspire researchers to tackle this neurological mystery and make a difference.
Absolutely. Absolutely. Yeah, I think that's really important. You know, we are doing some work behind the scenes right now. I am talking with the general practitioner college to find out kind of some things that are going on there. But you know, I was in a doctor's appointment. I went to get a second opinion the other day, and he pulled up, the doctor pulled up a page on his computer, the same page that I could find, and said, let's just go through these. And I was like, okay, here we go. Like, you know, there needs to be something more, or other people, doctors around. There's a few in Dunedin and Otago that have an interest in migraine, GPs, but there is not enough throughout the country, throughout New Zealand, to help support the amount of people that are living with migraine throughout New Zealand. Yeah, it is sad, but we will get there, and there will be change. Yeah, absolutely.
Yeah, and that's where making these connections through Migraine New Zealand, getting people together, collectively learning what we do know, what we don't know, where the gaps are, where we can make a difference is so important. I visited some really fantastic headache clinics internationally, and I can see what works really, really well, and I can see where we can potentially aim for. And it may be that we need to, you know, talk to the medical schools here in New Zealand as well, and I've been trying to do that from my position here as well, looking at how we might be able to get more headache medicine into the training curriculum, because I think the average globally is 2 hours. It's all that headache, you know, people get in their training. That's just not enough given the complexity and the number of people, right? So okay, we know those numbers. Let's see what we can do to change that.
Absolutely. Yeah, definitely. 2 hours is not enough. It doesn't even tick a box for the amount of time that those have a migraine attack for. It definitely does not do much. What are your thoughts on workplaces and things like that with migraine, people living with migraine and working? What are your thoughts on?
Well, I think this comes down to the awareness side of things, and something that it's maybe not comfortable for people to talk about, but if employers don't understand the impacts, they're never going to be able to put anything in place that might enable more flexibility in working life, such as when you have an attack, this is understood. So, you know, I don't like to describe migraine as a disability, but it is disabling and it is recognized as such. So why can it not be accommodated in that sense through other workplace considerations where a more visible disability might be taken account of? But, you know, for a long time, people have considered there is a stigma associated with it still, which is, you know, totally unacceptable. But I think people do often live in fear also of mentioning it because they may be judged. And so the more awareness we have, the more understanding, the more we have a casual conversation with our friends, our employers, our colleagues, the more we learn, perhaps the better understood and accommodated people living with migraine can be.
Absolutely.
That's just my personal opinion. And as I've clearly indicated, this is not a condition I have myself. So I cannot ever truly understand, but I try.
Yeah, absolutely. And I think that's really important that, you know, I lived in fear speaking out about having migraine because I started off back like 13 years ago with migraine with or without headache. So I only had the aura side of things and no headache. And that passed. I had that once a month almost. And then until 2019 when things got a lot worse for me and I was having dizzy spells, vertigo, and was then diagnosed with vestibular migraine. I was like, migraine shouldn't be a part of this word, you know, part of this diagnosis, which absolutely, there is so much more to just a headache, which is what the stigma is this is a headache, take a Panadol, take this, when there's so much more going on with in the body, and for someone who lives with migraine.
Yeah, absolutely. So yeah, let people understand, be brave, let them understand, and hopefully we can move forward together.
Absolutely. And what are your plans going forward, and like what are you currently working on down in Otago?
So we've got some really interesting things going on. We have a wonderful collaboration with the Danish Headache Centre. That's one of these great international places that does everything from primary research into migraine to initial diagnosis. So they have a fantastic clinic where people will be referred and they'll undergo proper tests, not just working through that little sheet that you described, but making sure it's not a type of tension type headache, you know, really properly working through every aspect to make sure that the diagnosis is correct and the right treatments can be tailored, be it something to do with lifestyle triggers or really anything, to all the way through to medicine. So I formed a great collaboration there, and we've been working with really amazing volunteers to identify new substances that cause migraine. So we talked about CGRP before, but it's unlikely to only be CGRP. It can't be, given the diversity that we've discussed in terms of migraine. So what other things are causing migraine? And there are some other hormones that are potential candidates. So we've been working with them, with patients who really bravely allow their migraine to be provoked with different substances. So in this case, there's another hormone we all have called amylin, and patients volunteered to be given amylin to see if it provoked migraine-like attack, and it did. So that gives us some new clues as to other potential treatments in the future.
Wow.
So we've been working on understanding how amylin works, and whether that might be a new treatment option or not, just as an example of something that we've been doing.
How big is your team down in Otago that you have?
My team down here at the moment is quite small. There's 2 of us at the moment, with another PhD student joining in a few months, but I still have some people up in Auckland as well.
Wow. Yeah.
So, we've got, overall 5 to 10 people, I'd say, working on making some impact and doing some research that will hopefully give us some clues to treat migraine or understand it better in the future.
Yeah, absolutely. That's amazing. So cool. I want to just quickly, it dawned on me before, is there anything you know of the difference between men and women living with migraine? I know I've just been doing some research myself into men with migraine, and a lot of men don't speak up because of the stigma. It's just a headache. And obviously there are predominantly more women that have migraine disease. Do you know anything about men with migraine, or CGRPs working with males? Yeah.
Not enough to give you any sensible answers. I mean, absolutely, we look at the broad statistics and we say migraine's more prevalent in women, but it also occurs in men. The granularity to that then is really, really challenging. And it also means, for example, that in all the clinical trials that have been done for the CGRP therapies, they are hugely skewed towards women. And that's good, because often it's the other way around. But in this case, the actual data to know whether they have a better impact in women than men, we don't have enough data. We don't know. But yeah, just to any men out there listening about here, do speak up as well. I know it's hard, but I know many, not as many, but I know a number of brave men who have talked about it, and actually having that conversation, it can lift a weight.
Absolutely. One person has joined the Migraine New Zealand chat group just the other day, and he has reached out to me, so that will be coming soon when I get his story in. But I talk a lot about the woman with migraine. However, I know that for men it can be the same debilitating stigma around it, and if not even more stigma for men, because men are all like, oh, just a headache. It's which is not true, and there's so much more to it than being just a headache. So absolutely, if you're out there and you're listening, do please reach out and know that you are not alone. And there is others that can help and support and help you, lift you, that sort of stuff. And is there anything else that you want to say? Any other things you want to mention?
No, not really, but I don't think so. I think, look, we've just all got to support each other here. We've got to build this community in New Zealand. We've got to raise this awareness. We've just got to build that critical mass. We've got all of you out there with your individual situations in how you're living with migraine, coming together as a community, raising awareness, getting this on the radar for education, for research, for health, medication funding, all of those things. Collectively, we can make a difference.
Absolutely. And you are not alone. So if you are seeing this for the first time, you've realized there's a Migraine New Zealand, do please reach out and head to our webpage or social medias. We're on Migraine New Zealand. do absolutely reach out and remember that you are not alone. And there is a lot of us, and we can make a change. Yeah, absolutely. So thank you very much, Debbie, and yeah.
Thanks for inviting me, and I hope this has been helpful to at least some of you out there, and I'm really glad to being able to have a chat about it today. Thanks.
Yeah, absolutely. Thank you very much.